All right, here we go. It's DocTalk time. Dr. Jenna Burton is in the house. And we're going to be talking about inflammatory bowel disease. I got it right this time because this is take 2. And first time around, kind of messed it up a little bit.
Well, you've actually did everyone a favour, James, because everyone gets IBS and IBD confused. So I think that's something we'll probably start with quite early on.
And we've brought the man in to talk to us about this.
Well, he's probably the one that's going to tell us the difference.
Who is he?
This is Dr. Hossam from Mediclinic City. You're in City Hospital, aren't you?
Yeah, I am. Yeah, and thanks for having me over, guys.
It's great to have you on the podcast.
It is a pleasure. I do like the setup, and it's it's good that I can at least shed some light on something that affects people of a variety of ages, and there's a bit of mystery around it, shall we say, especially with the advent of Google.
Isn't this is like you're both medical professionals.
Professor Google.
This is your worst enemy because, I mean, just like me, I went in, I Googled, I'm looking at stuff, I'm looking at symptoms, and I'm looking at things, I'm going, you know what? I've got like 5 of these things going on, or it's like, maybe it's me. It's like, oh man, it's got to make it really hard.
No, for sure. And I think it's really important that, things are structured and clear when people do come to see doctors in order to get the right diagnosis made right from the start. Because once you add that element of confusion, you can sometimes do more harm than good, either by treating something that isn't there or ignoring something that is there. So it's really quite important to be quite systematic at how you approach this.
So you've got Dr. Google, then you've got friends,
and
then you got friends of a friend who had a cousin and then their great uncle.
Oh yeah, for sure.
I mean, I think we need to give a little shout out to Professor Google, because at least it makes people a little bit more health aware.
Yeah.
So they are more ready.
Health aware or health paranoid?
A little bit of both.
Okay.
Both. Definitely paranoia is there.
Do you have stocks in Google or something? Like, why are you being so kind to Google today?
I think just because I think it's really important. We often talk about people, especially men, and especially of a certain generation, ignore things. And sometimes with the help of Professor Google, people might have checked out their symptoms, maybe their wives, and I'm being totally, what's the word I'm looking for? I'm just...
You're being very politically correct here.
I'm being very politically incorrect, yeah. Incorrect. But, people often will say, and I've read about this and I read about this. And so they then go and see the doctor. Yeah. However, there are the people that have got printouts. They are convinced this is what they have and they don't necessarily have it. And so it can be difficult. So it's like a double-edged sword. Yeah.
So what is IBD?
Okay. So that's, let's start from the top. So in summary, it's a summary of, use the same word twice. It's a combination of conditions that share some common elements and some things that makes them different.
So right off the top, it's not
one condition.
It's not one thing.
Yeah. If I can just subdivide it without making it too onerous on our listeners, into Crohn's disease and ulcerative colitis. If we can think of our immune system as a defense mechanism that helps protect us against, diseases and infections and such. And occasionally there are mishaps where this same defense mechanism can cause damage and inflammation within our own body. Easiest way to put it is a lot of people know people with eczema, which is a skin condition, and you can visibly see a rash in an elbow or a joint or such. This condition, it's not exactly the same, but quite similar, where you find the inflammation within the gut. And with ulcerative colitis, the inflammation starts, excuse me if I use this term, I use it medically, from the rectum and then goes upwards into whatever part of the colon it may affect. However, with Crohn's disease, it can be any part of the digestive tract, but predominantly at the end of the small bowel, where we see the majority of patients have that kind of condition affecting them. And why it's important to try and differentiate, if possible, between both. It's because of there are medicines that work for both, but there are some medicines that work for one better than the other. And even within those medicines, some medicines work better in the colon, some medicines work better in the small bowel. So you'd like to tailor treatment according to what the patient has, rather than just throw something at the condition in order to avoid getting side effects, if you can avoid them, plus getting a better outcome for what you're trying to treat. So there are a few considerations there, but you need to kind of get all the assessments out of the way early, and then discuss your findings with the patient, educate the patient. Patient education is without a doubt the most important part of the whole disease journey, because if you have someone in front of you that has a combination of symptoms, sometimes they don't have much in the form of symptoms, maybe an abnormal test result, on routine screening or what have you. If you're not involving them in what this all means, then it doesn't matter what smart diagnosis you come up with or what drug you prescribe. They're not going to take it. They're going to leave. And then this just remains unresolved. So
when we're talking about Crohn's or ulcerative colitis, do they present the same?
They have some common elements, but they do present somewhat differently. With ulcerative colitis, the gamut of diarrhea and blood in the stool is commoner than getting pain. However, with Crohn's disease, pain can be more predominant. I think this is mainly because of the fact that with ulcerative colitis, the inflammation is mainly superficial and it affects the colon. And in the colon, it's where you kind of absorb water. So if you could think of that surface being inflamed, you don't absorb water very well. You have more diarrhea. And because it starts in the rectum, if you have inflammation in the rectum, you're more likely to see blood. However, if you have inflammation in the small bowel, you're less likely to see blood, because the area that's affected is generally somewhat full thickness. So you get inflammation starting from one layer of the colon and it goes all the way through. Diarrhea you can have, but it's less so. And the other thing is that Crohn's disease has complications that ulcerative colitis don't. So sometimes you have fistulation or narrowing, what we call medically as stricturing. So some considerations there, but without trying to make it sound too medical, the differences are important when it comes to managing the patient.
I was just going to say, butt in as well, often when patients come, when they have Crohn's disease, you'll often find, because it can affect the small bowel as well, where you absorb nutrients, you might find that they are a bit depleted in nutrients. They might have had some weight loss. Maybe they have a little bit more fever, a little bit more stomach pain, as we mentioned. And they can also have lots of other things that go on in their body, a little bit more than with ulcerative colitis. But yeah, it's one of those things that people may present and you have an idea of what's going on. And I'm sure Dr. Hossam will correct me if I'm incorrect.
Hit the nail on the head there. That's completely true.
Yeah, until you do a colonoscopy and you start to investigate further, you can't really tell which one it is until you've actually seen it sort of with the magnifying glass, as it were.
Do these two conditions, do they start developing and they can go unnoticed, or we just get, as the patient just gets used to it? And
so that's a really good point. So they can either from the start make themselves really obvious, or it can be on and off for a while, where somebody then later on comes with a, let's say like a complication of the inflammation that's happened over time. It really just depends on the patient, because there are some factors that come to play here. So the main genetics is really important.
So this could run in the family.
It could. It's not a direct link. So just because you have a family member doesn't mean you're going to get it, but the chances are higher. And then now we're more aware of the role of the microbiome in how disease manifests itself.
There's a little midgie that's harassing you on your microphone.
I know. I'm popular with this little thing, so I'm trying to let it not interfere with what I'm trying to say. So, what was I saying?
About the gut biome.
Yeah, the microbiome. And speaking of Dr. Google, a lot of people have become more aware of this, and I'm a big advocate of a lot of the research that's come out regarding this. So we're all born with a whole flora of bacteria within our colon, and it changes from birth. So whether you're born via C-section or natural delivery, whether you're breastfed or not. So just from the start, everybody's journey separates which country you lived in, what antibiotics you took, etc.
So complicated.
It is. And it's just important to appreciate all the factors involved. So some patients do come and say, what did I do wrong? Why does this happen to me? Because a lot of it happens with people that are younger. It's a disease of the young, and young people. Yeah. And I think
I didn't realize that.
Which IBD?
Yeah.
Yeah, it's between 15 to 40 is the typical age range, isn't it, for presentation? Right. So they can be a bit older as well, but often in teenagers.
And in that group, a lot of people are young. They've got a lot going on in their life. They just want to get on with it. You know, they're in university. They're in relationships. They want to settle down. They want to have children. They want to progress in their careers. And, this can interfere with a lot of these things. So it's really important to try and make them have the most in life and fulfill everything that they want to fulfill by making this less of an issue, by treating it early with the right meds, hopefully avoiding all the complications that can occur with it. And, that's why it's really important to educate people so that they know what's going on.
So potentially we've got an issue of hereditary.
Yeah.
People tend to be younger. Do we have any other things that factor into this that might make me more predisposed?
Yeah, sure. So the microbiome is something that I briefly mentioned on without going too much into it. And then the other thing is like a lot of, there are elements such as stress and that, people that generally speaking have difficult eating patterns and difficult sleeping patterns.
You're describing university students to the letter, and young folks, right? Yeah. Relationships, school, for sure. Pressure from family. It's like the tsunami of things.
It's tough. But of course, all this affects your immunity,
right?
Just if you look at it that way. And the other thing is smoking.
Oh, that's an interesting one, actually. Yeah.
In this specific group of conditions, Crohn's disease, in particular, smoking is incredibly damaging. And I am very clear with a lot of patients that do get diagnosed with this condition that stopping it is as powerful as having a course of steroids. So if you manage to do that, then you really do kind of improve your chances in getting over the inflammation that you're under.
Like colon, lungs, smoking. I mean, I wouldn't put the two together. I think, smoke goes into your lungs. Hey, it's all over. But smoking can be a contributing factor. It's crazy.
And the flip side is that smoking with ulcerative colitis has the reverse effect. Now, doesn't mean...
Let me just be clear.
I want to go... This is not a controversy. I got to be very clear about this. Yeah. So what we sometimes see is that people that smoke, when they stop smoking, we diagnose them with ulcerative colitis. It happens. Yeah. But it does not mean that you need to go back smoking. Because overall, the disadvantages and the harm that you do through smoking significantly outweigh any minor protective benefits or preventative benefits that smoking may induce with that group of patients. So all in all, smoking's a no-go for both conditions.
Yeah, generally smoking is bad. We don't like that in medicine. Yeah. But one thing we should think about is we've talked or alluded to university students, people that are young being diagnosed with a condition that causes diarrhea, potentially blood loss, passing loads of mucus, stomach pain. One, it's not nice for anybody to have. And two, it's embarrassing. It's something that people are really self-conscious of. And as Hossam said, it's something that maybe they might be dating, they're trying to settle down, they're trying to have children with a condition like this. Yeah. Sometimes it might require hospital admission as well for IV steroids or to tweak their medications for investigations. And a lot of these people can become quite depressed as well. And you often find with any long-term condition that you diagnose, depression can go hand in hand. And, that's something that you've got to be aware of as well. And I guess that's something more maybe a GP would be looking out for than in your instance, but it is something to bear in mind. It's not a pleasant condition for anybody.
Body image is really important. Really good, important point you put there, Jenna. And you see a lot of advocates, young advocates for body image in inflammatory bowel disease, including footballers. There are a few Manchester United footballers. I'm sorry about that. I know you may not be.
Oh, Manchester United. Oh, my dad wouldn't approve.
So, awareness is incredibly important. And, there is an awareness month out there, and there is with social media, there's a lot of, positive, let's say, messages and people that are trying to help everyone that may think that they're alone with this condition when there aren't. And I always encourage whoever comes and sees me with this condition not only to educate themselves, but to try and meet up with people that may benefit them with trying to understand the disease more. This is a double-edged sword because, as you can appreciate, even the fingers in your hands are all different lengths, so not every condition is the same. It's very important to make that point. So just because someone else had a different experience than yourself, if you have this condition, it doesn't mean if you do the same thing that it's going to apply to you. And that's
so tricky.
Yeah.
I've read also that when we talk about things that can contribute to us having an episode of IBD, overuse of things like ibuprofen or long-term use.
Yes.
Is that just Dr. Google talking, or is
no? This isn't Dr. Google. In fact, you see this with patients that are diagnosed. We tend to tell them to avoid non-steroidal anti-inflammatories because this specific class of drugs can cause inflammation in any part of the gut. If
it is in the little leaflet as well when you read it, like that's one of the precautions.
So
you've been reading the leaflets to the letter there, James.
Always.
No, now I finally met the guy that reads the leaflet. So,
this is the one.
I've taken the box back to the thing and said, "Where's the leaflet? There's no leaflet in here. Like, where's the documentation?" So, haven't you read it once before? I read it every time in case it's changed.
Can I just say,
I get double glasses on. It's like I look like a surgeon.
This Professor Google can be difficult, but the guy that reads the leaflet is also a problem. Yeah.
No, we need to have a talk after this, James. So I think there are two things to think about here. First of all, when you investigate someone with possible IBD, if they're taking that class of drugs, what you find could be just due to the drug. So it can be quite confusing. It could cause a kind of a wrong diagnosis. So it's really important to try and tell them that actually come off all this, and then we'll start investigating.
How long would they, if someone's come in, they're presenting symptoms, say they're on ibuprofen, how long do they have to be off it typically?
It really depends how much they were taking.
Like everything. So
yeah, it depends how much. If it's just the odd one, then just 2 to 4 weeks would be enough. But if they're taking quite a high regular dose, then you may want to take that with a pinch of salt. There isn't a specific time frame or a formula to go with. But whoever walks in that door, you need to kind of get a general idea of what their use is. And, a lot of people use these drugs because they're bought off the counter and they're seen as harmless. They must be safe.
They must be okay.
Yeah. And a lot of other physicians prescribe them because, you feel good. If you've got a headache and you take it, you feel good. If you've got, a menstrual cycle type, cramp, you take it, it feels good. Joints, if they hurt, it feels, so it's not an unreasonable thing to take. But whenever you come with gut symptoms, you just need to bear that in mind. And being wrongly diagnosed can cause harm. So it's really important to try and reduce the chances of having a wrong diagnosis. And then to the flip side, someone that wasn't having any non-steroidal anti-inflammatories, and then you diagnose them, you tell them try and avoid this class of drug because you have the damage from the immune system and then you have the damage from the drug, and you're just trying to avoid damage full stop.
Oh, man. Yeah. Well, I mean, from a clinical side, this is a really interesting area of medicine to practice because there are so many moving pieces and it's so different for every person. Like no one's really the same. And it's really like being a detective to find what's going on and what's contributing to this and what are we going to do and how are we going to deal with it.
Yeah, but that's the problem sometimes is it is like being a detective.
And the amount of time you've got to invest.
But people can get missed. So a very common scenario is a patient comes in, they have some new onset diarrhea potentially, maybe they're passing a little bit of mucus, bit of stomach cramps, and is this IBS or is this IBD, and when do you refer on? So irritable bowel syndrome is like, it's a more mild type of inflammation of the gut. There's debate as to what causes it. It's a benign condition. So rarely, if ever, needs referral over to the hospital and is usually managed in a sort of general practice outpatient setting. And there's been debate, is it due to over infection in the past? Is it due to diet? Is it people can't break down certain substances and that what can cause it? Is it a psychosomatic illness? So it's actually due to one out of stress or depression or whatever it may be. And IBD is the immune system attacking the gut and is very definitely something that will need a colonoscopy and to have long-term treatment and usually be overseen by a consultant gastroenterologist. And so a lot of people can be misdiagnosed until their symptoms get really quite severe. And so that's it. You have got to have your best detective hat on at all times to make sure that the right person gets the right treatment, because we've not really alluded to treatments yet, but the treatment is very, very, very different.
So what is the treatment? Mm-hmm. Nice segue, Jenna.
Well, thanks, James. I've been working on it.
That's nicely done. I'm just going to take a step back before treatment.
Please.
Let's talk about what investigations are done for this condition. So normally, anybody that comes in, depending on how they present, they can be subtle or it can be quite obvious. So if somebody comes in with blood in the stool, for instance, you're more likely to proceed with a colonoscopy early on. But if somebody has a bit of cramp and the odd loose stool, especially if they're not, older and they're young, you can proceed with just simple stool testing, looking for inflammation. A very common test is called the Calprotectin Test, which basically is a stool test for inflammation. It's not a diagnostic test that you have inflammatory bowel disease, but it's a good first step. And then you try and do other blood tests to see if you have inflammation in the blood and such, and you're not anemic, and just routine simple testing, ultrasound, if you have abdominal pain and such. And if the stool tests show no infection, if there is inflammation, if there's inflammation in the blood, then your spidey sense tingles, and then you go, okay, I need to take it a step further here, explaining to the patient why you're taking it a step further so that they understand the logic behind it. And at that point, you can proceed with a colonoscopy, which is a test involving a flexible scope that looks at the colon. You try and, at the same time, if possible, obtain samples. So the diagnostic criteria there are what we would call endoscopic diagnostic criteria and then histological diagnostic criteria. So there are two levels of evidence. And then at the same time, because Crohn's disease affects the small bowel, a lot of people may get an MRI of the small bowel because the scope can't go past the end of the small bowel far. And that would be radiological evidence. Sometimes you can get a CT scan if you suspect things like a fistula or a collection. Fistula is an abnormal connection between part of the gut to another part of the body, and a collection just means a collection. It could be fluid or pus or whatever it is. But you can't see that with endoscopy, and MRIs aren't generally that good seeing that. So you choose it depending on the system. And once you have all that information, so you've got your radiological criteria, you've got your endoscopic criteria, you've got your histological criteria, and you've got this kind of simple blood testing before that. And you sit with the patient and say, right, based on this evidence, you have this disease, or you don't have this. And depending on what part, if it's Crohn's disease or ulcerative colitis, what part of the gut it affects, then you can provide treatment accordingly. And treatment involves diet. It involves medication. Medication has different classes. It involves lifestyle changes, as I alluded to earlier with the smoking part of things. And then with some patients, surgery may be an option depending on what we find. Unfortunately, despite all the efforts and the drugs that are available, 20% of patients, and in some cases up to 30%, will require surgery, and medication will not work for them.
30%?
Yeah.
If you catch this earlier, is obviously are there better results if one manages diet and et cetera? And is diet a big part of this as well? Yes,
it is. So specifically with Crohn's disease, diet is a major part of this. A lot of research has been done with the pediatric population, because we try and avoid giving them medication because they're at a sensitive age when it comes to growth and such. And we found that there's a specific aspect where we bring diet back to really, it's called an elemental diet. You bring it back to the basic bare bones, and you find that it reduces inflammation in the gut significantly. Without trying to use this term multiple times, but really it is like taking a course of steroids.
Wow.
Working in a lot of places in the past, like when I was working in Cambridge, the population there seemed to be, very anti-steroid, and they're happy to proceed with this diet. But then in more urban areas, people are less inclined to do so because it's harder. And really the main issue with the diet when it comes to that specific diet is compliance, because it's really quite bland. So it does help certain people. And of course, not being extreme about this is something that reduces inflammation, but there are also other diets that we can recommend that can reduce symptoms, but not necessarily reducing inflammation. So for sure, a dietitian's input is incredibly important in a patient's journey. And not addressing that is it's low-hanging fruit. It's an easy win. And a lot of patients do want to know what they're putting in their body and whether it's doing good or bad to them.
I mean, in this era, we're really thinking about food. We're talking more about gut biomes. So that must make it a lot easier for you to get people to buy into diet change and lifestyle change.
Oh, for sure. I mean, I don't know about you guys, but I'm a different person today than I was 10 years ago, than 20 years ago when I was at university. Oh, God, it feels like a long time ago. I shouldn't be giving my age.
Living on pot noodles.
Yeah. So at the moment, even though I do enjoy the odd, cheat meal, overall, I do care about what I have. And it is important for me to know how I'm treating myself with what I'm eating, in order to sometimes avoiding issues is better than dealing with them. So if I can, I'll just do my bit. And if I can't, then I'll take the medication for it.
Yeah.
I think, like you say, though, a lot of it is put back onto the patient and what do they want. And all you can do is offer them the treatments that are available, and then it's up to them. You can't force them to have a more elemental diet. It's very difficult sometimes with children as well. They're going to birthday parties. That's how I found
the chicken nuggets and the French fries and the stuff, and grilled cheese sandwich with Kraft cheddar cheese slices in a piece of plastic. Come on, that's
oh my gosh,
can't live without that stuff.
But at the same time as well, if you can educate them from a young age, it can be helpful. And Dr. Hossam alluded to surgery, and just to clarify, that is actually to remove a portion of the bowel. Sometimes people will end up with a bag where they basically, rather than either go in the toilet, they will have a collection into a bag, which again, we talked about the more social aspects of the disease. And that's a huge thing for a young person to go through. And again, as you said, you'll see a lot of people on Instagram proudly wearing their bag and parading it around, which is great. There's a lot of sort of pro body image with a bag. But still, it's still an awful lot for somebody to have to take. So if you can encourage them to try and do as much as they can without having to go to such radical measures, the better.
Once someone's treated, so they've been diagnosed, they've gone through treatment, can this be cured?
So it depends what your definition of cure is. If the problem's with your immune system, you can't get rid of your immune system. It's
you can't reset the immune system. You can't just there's not a magic reset that.
So if someone has a tumor, you remove the tumor. If someone has an infection, you kill the infection. But if it's your own genetics causing the damage, then what you can do is you can try and, for want of a better word, cure or control it in order for this abnormal kind of response to disappear. But you can't get rid of the fact that you are more predisposed to have this condition.
That has other problems as well, because if you modify people's immune system, it can mean they're more susceptible to other illnesses. So you'll often find that they catch colds easier. Maybe they probably had COVID 5-6 times. There are knock-on effects. And we've talked about this so many times, James, that, we always say you don't get anything for free. So you can help modify their Crohn's or ulcerative colitis, but there are knock-on effects.
So, sorry to interrupt you. I just want to add to what Jenna said. Super important point. So when patients come with this condition, the first thing I do before putting them on immunosuppression is send them to someone in Gemma's field, like a consultant family physician, and have all their vaccines out of the way.
Okay.
Because you're going to put them on medication that alters their immune system. They're not allowed live vaccines, but they can have, and most luckily most vaccines are non-live vaccines. So you try and give them the best protection before you start the medication. When they start the medication, they also need updates and boosters, and you need to, hand washing and trying to avoid people that are unwell and X, Y, and Z. So all of this is also another
it's a complete life
string
change
in the
in a
bow,
sense.
of treatment. But it's not as extreme as someone, for example, going through like something as radical as a bone marrow transplantation. It's still you more or less can have a normal life. You just need to take normal precautions. That's about it.
Is this an area? I mean, and I say this is kind of a leading question because I already have the answer in my head. Because it's interesting. So the question is, and I'm gonna tell you what the question is, then I'm gonna explain something, then I'm gonna come back and get your take on this.
I'm excited.
Yeah.
Let me know.
You ready? You ready?
So
I'm ready.
So the first part is, I know two people who've gone through this. One old and one young. So this is very interesting. The younger person has kept the bag. The older person had everything. Bag is gone, so I don't. Whatever was done is done. Interesting case in both scenarios. We never talk about this. And maybe in their families they do, but I mean, I've met both of them many times post-diagnosis and post-treatments. It's not something we talk about ever. Yet there's always a million questions, but we never really talk about it. And so that leading into the question, is this something that people don't talk about enough to A, understand, and B, help others? As you said, like almost 30% of people who could be diagnosed could need to have some form of operative thing. Just to know that this is out there and start thinking more about it. IBD. Did you get that sense?
It's a part of the body that a lot of people don't like to discuss.
Yeah, we don't talk about the washroom. I mean, I do.
You do.
I do. I'm always looking every day.
Yeah, he's very open.
I should have a spreadsheet because
Or maybe not. Yeah.
I'm thinking. I think I need a spreadsheet to track.
But you're
with
very
images.
open, and you've probably created that environment for your children. But generally, I remember having a chat with my grandma, and if she had an upset stomach, she wouldn't tell my granddad. It was considered a real or no go.
Yeah, taboo.
So I guess that still lingers on in today's population. I don't know.
I think I don't think there's anything to be ashamed of, and I don't think people have anything to hide here. But it is personal information. So however anyone wants to share or not share, that is at the end of the day up to them. And people do have different perceptions on how people will respond to that. And of course, like a lot of things, sometimes just sharing a bit of information with someone leads to so many different questions. They don't want to go through that journey again.
Yeah.
They're just like, look, I've been through it.
Yeah.
I'm going to just, I'd rather meet my friend to just enjoy a meal and just, that's why I'm here. And life has so many pressures these days that one of the major pressures that, I don't know about yourself, but most people find is the kind of the mental aspect of things. We're all under a degree of stress, and a lot of people feel anxious in certain situations. Add to that perception and body image and how your overall well-being is affected. I can totally understand why some people just want to just meet you and just have a good time and talk about that sort of stuff.
Do you find the prevalence of this is going up, or is it it's really stayed the same throughout the course of your practice?
I think what's really obvious from the beginning of my journey from medical school to now is two things. First of all, people are more aware of this condition. Clinicians in particular are more aware of this condition. We have, and because of that, we're diagnosing more people that would have been missed in the past. Our diagnostic criteria has been more refined, so it's not as vague as it used to be. And medication also is much more tailored to the patient. So because of all these factors, we tend to pick more people up from the population that have it that we could have missed in the past. We're also becoming more and more aware of the specific genes that are involved in this. And we're trying to use this in research in the future to do two things. First of all, possibly, it's not there yet, use the genetic element as a diagnostic criteria. And the second element is using the genetic information to know which drugs work best with which patients.
Okay.
And this has two sides of it. First of all, the drug has side effects, so we could avoid giving the drug if we know from the genetic profile that it's going to cause the side effects, rather than just monitoring, which is a lot of what we do now. Now we monitor them, they get the side effects, we stop the drug. So if we know this from the beginning, we can avoid that.
Yeah.
And then the second thing is maybe we can find out from the genes, okay, from all this drug has a better chance of success. So rather than try a few drugs to get to the right one, we can just pick the right one from the beginning. We're not there yet, but there's a lot of good work happening in the background. And I'm very confident we're going to get there at some point in the future.
Do you think there's any way that knowing somebody that's been born with the genetic material to suggest that they're going to go on to develop Crohn's or ulcerative colitis, there's any way of almost getting in there early and trying to put them on an elemental diet from a young age and almost hope that the disease never... Sorry, James, am I just playing footsie with you?
Yeah, you're playing
Sorry,
footsie.
James.
It's okay.
By the way, just to be clear, I'm not part of any of this.
It's just the thing me and James got going on. But do you think that there's a way of trying to almost sidestep to some degree, obviously not entirely, but to some degree sidestep the actual, the larger, more severe presentations of the disease?
So like a preventative kind of test. Sometimes this applies to certain disease processes when, like, say, a parent may have it or two parents may have it, and they want to avoid their kids going through symptoms or complications and identify diseases early. But I don't think, because of the fact that this is involving multiple genes, that this is going to be something that is used in that context. If it was just 1, 2, 3, 4 genes, or even a few more, then fine. But if there's so many different genes, they all express themselves somewhat differently. So even if you may have it, it doesn't mean that you're going to get the disease. And do you want to know and then live in fear of when you get a symptom, which could be nothing? That,
it's like catch-22, isn't it?
So I think most of the work at the moment is not in that field, but things can change. And if we do eventually come up with, like, saying, actually, this is such a strong gene that if you test for this, then the likelihood is X amount, and it's a high likelihood, then maybe there comes a kind of a point in life when someone has like a colonoscopy, and if everything's fine then. But in all honesty, this is all theoretical, and it's not there.
I mean, or we all try and encourage our children and ourselves to have a more elemental diet from the offset, which is what there's a huge
stop
campaign
the processed
for.
Food.
Yeah.
So stop eating as much processed food. I mean, it's interesting.
You're very right about the processed food, because what's processed and what's not. There's a lot of movement towards a more plant-based diet, and that's excellent, and I'm all for that for a variety of reasons. But then you see a lot of the plant-based products out there that are so super processed in order to taste similar to appease the palates of people that weren't vegetarian before or vegan. That you have to kind of think, there's quite a lot of salt in this. There's already a lot of this in this.
What chemicals are used in the process to make it? And I go back to a tape cassette that I was listening to 25 years ago. And there was a portion of that cassette was with Dr. David Suzuki talking about food storage, of all things. And he was talking about plastics, actually. So this is like 25 years ago, we're talking about plastic. He's talking about storage, and he's talking about plastics leaching into our diets. Now, and he's going, cans. He says, canned food. Cans are lined with plastic, and our things are coming in. How much of plastics are leaching into what we eat, what we drink. So even this fresh stuff, and his thing was, look, he says, we know that it's happening. We just don't know what it's doing. Sure. And then over a long period of time, what might that impact be on you and I? And who knows? But, if you can eliminate some of these things, at least that's one less tick box of, hey, this might have an effect on something over a period of time. So.
Like with all information and all advice, practicality and sustainability are super important. Yeah. So me and you can have a chat, and we can talk about all the things that are good for us. Yeah. But if we can't practically implement them, or if we can't maintain them for a kind of a regular kind of day-to-day practice, then it's not going to be as helpful.
Exactly.
And there's a lot of advice there that says this is bad for you, this is bad for you, or this is good for you. And you find that the good stuff is super expensive.
Yeah.
And it's like, okay, I know, but I can't just live off this. This is really expensive. And then the stuff that's really bad for you, it's like in everything. So I have to always, I know always when someone comes to see me, say in a clinical setting, I always put myself in their shoes. I'm like, look, I can sit here and tell you that all this is bad or all this is good. But really, how you implement it is more important than what I say. Yeah. And in a strange way, and you may find this strange too, Jenna, I've actually tried a lot of the diets that I advise.
Yeah.
When I was,
I think that's dedication.
That's really good.
When I was training, I even put like a nasogastric tube. I didn't do anything more than that, but I put it just to see how that feels.
Oh my! Do you do it to yourself?
No, I didn't go that far.
I was going to say
someone put the tube, but I stayed with it for a whole day just to kind of appreciate it. So
I only say that because a friend of mine did self-catheterize himself in a hospital when he was delirious. That's why I asked the question. Yeah.
Okay, maybe I should meet this friend of yours.
This is the friend.
This is the dancing guy.
We were talking about my friend beforehand because he's crazy and he sends crazy videos, and so we were just
dresses like Kermit the Frog.
Yeah, he does.
I hope he didn't send the catheterization video.
Luckily, there was no imagery of
that. but yeah, you then understand what it means. Like even what may seem simple, but asking someone to go gluten free. Yeah. It's not easy.
No, it's hard.
It's really hard.
You start looking at everything that's got gluten in it, things you don't even realize have gluten in them. It's like, really?
Gravy granules.
I know.
Devastating.
I know.
Okay, I'm going to put that to my list.
Luckily, Marks and Spencer's, I just like to say, do offer gluten-free gravy granules. So all is not lost.
For everyone out there, make sure you write that down.
But I think it's kind of an endemic issue of the way society has evolved on how much we just go to the grocery store and buy and don't think about where it came from, what's gone into that process. And even, like again, frozen vegetables, and you get them, and I often say to people, you ever been by a frozen vegetable factory? Oh, okay. Because they come out and they're nice in a bag, but the smell of all of the stuff that they use to boil and shred and peel, and it's horrible. It does not smell good going by one of these places.
I'll take your word for it.
Oh, it's really horrible. But that's that in the end of the day, that's what we want.
And it's convenience. And
convenience,
people's lives are fast, and everyone wants to eat on the go.
Yeah.
And it's handy to have in the freezer, of course. So, and as Dr. Hossam said, and we say every week, moderation is key, and
sustainability of change practice is a big one. And I think COVID actually gave us a little window into this and how much we can sustain. And I'm thinking, just people who were now making their own bread and people who were, XYZ, they still, we had 2 years. We're just finishing 2 years, so we had a good year and a half where people suddenly were, I'm going to do all this. And I often say to people, how many are still doing this stuff?
Yeah, for sure.
And I think that, I don't have any statistics, but looking around and talking to people in general, anecdotally, not many. No. They've just, I don't make bread anymore. I just buy it. It's like, really? Why wouldn't you just keep doing it? It's
time, James, time. That's the problem is, it's always a fight, isn't it? So people had this lovely abundance of time during COVID lockdown, which was one of the only saving graces. Yeah. But then sadly people just slip back into old habits.
And then that stress kicks in, and next thing you know,
oh my God, the world, like who would have thought, like what we're facing today is what we would have faced when we were facing COVID. Everything just moves so quickly, and a lot of people, you can see this in the news. A lot of people are worrying about the cost of living and security and things like that. So priorities change, I suppose. But I do miss the smell of sourdough.
One last question, and this is, Hossam, what got you into this specialty? Why?
That's a good question.
Why'd you go this direction?
That's a good question.
Can I just say, it's a really good question because I still have PTSD from my gastroenterology ward as an F1.
Yeah, that is really good. I don't blame you. And I do love what I do. So I'm going to be quite brief about this. So first of all, a lot of doctors, their first job sticks with them the most. My first job was in gastroenterology. As a medical student, I was attached to a lot of firms, but as a doctor, my first job was in gastroenterology, and I had an excellent consultant, and mentors really leave a positive impression. If he was bad, then I wouldn't have liked it. Second of all, after doing my junior training, I was interested in surgery, but I didn't want to spend all my days in theatre. And I loved the medical aspect, as we said, the investigative aspect and the kind of thinking aspect. Not as extreme as Dr. House, but just that kind of cerebral element. But I didn't want to just end up doing ward rounds every day, day in, day out, looking at numbers. And I think there are maybe 3 or maybe 4 specialties in medicine, gastroenterology being one of them, where you can do the medical aspect, and then we have endoscopy. So we have the practical aspect. So it's the variety that keeps it interesting for me. Plus, I get to meet people that are young and old, of different backgrounds, different financial backgrounds, and it's rewarding in the sense that it's quite varied, and it has a lot of elements involved when it's not just one thing. So I get bored quickly, James, is the thing. So I need to.
Oh, this table is of like we're kindred spirits here.
I was going to say, I wouldn't worry. Every time somebody comes on, James always wants to do that job next.
No, I don't want to do this job, but I'm going to do the spreadsheet.
Okay.
With images. I think if I track the images, then, if I ever have to come in and see you and I just go, here it is, what do you think?
Yeah.
I can bring it in for you if you want.
He will refer you over to a different consultant quite quickly.
I thank you in advance for that.
Actually, one of the things after all of these podcasts, I'm thinking I need a stool sample containers at home just to collect every now and then and just periodically get a test done on them. It's like, I kind of feel, because I often talk about podcasting and thing is you've got valuable content that people just never record. And I'm kind of thinking, I got valuable content that's not being tested. So
this reminds me of my granddad turning up. Every time he went to see his doctor, he took a jam jar of urine. A big mason jar.
I'm starting to think that I should have urine samples and stool samples every time I go. I say, hey, brought you some presents.
Well,
as much as I want to say, always be prepared. I can tell you that you don't need to go that far. And I know, like, being aware is super important, but at the same time, and to all our listeners out there, just live your life. There's just so much stuff out there that people can easily get caught up in. And as I said, Google can be a good source of information, but if you have a bit of loose stool or tummy cramp, it's probably nothing. But if it's happening quite regularly, then it's worth checking out.
And the first step on that journey is go to your GP.
For sure. So, common things are common, and being sensible is always the best way forwards. Health anxiety can also be a source of a lot of angst and issues for a lot of patients. So it's important to try and avoid that too.
And we can find you, Dr. Hossam, at the City Hospital, Mediclinic City Hospital.
That is right. If
City Hospital, Mediclinic, City Hospital.
I know. Now you never know. Is it Mediclinic, City Hospital, Mediclinic? Anyway, it's City Hospital.
Yeah, City Hospital. And always happy to, answer all your questions. Really thank you for inviting me. And, I hope anybody that's been listening to us today gets some valuable information. And if you do get some questions on the side, I'll be happy to kind of take them on and answer them at any point.
Wonderful. Dr. Hossam, thank you very much. This has been a lot of fun. Very informative, very educational, absolutely entertaining. So we struck all the boxes. Jenna, as always.
Thank you very much,
This was
James.
tons of fun.
And thanks for coming, Dr. Hossam.
Yeah, we'll do it all again really soon.
Me.